All right, so this chapter is on children with sensory and neurological conditions. Some of it is things that you have covered before in your adult courses, like meningitis, for instance. Some of it will be new. We will briefly go over some of the stuff that's more of a review. Whereas we may focus on the stuff that you may not have heard before, but make sure the stuff that is a review that you're reviewing that information in your textbook and your ATI book. So first we'll talk about sensory conditions, specifically with the ears and eyes. So with the ears, here is an example to show you. Here's a picture of the ear, which you've done in anatomy and physiology. And at the bottom, this is more important because this really outlines why children under the age of 3 have a much higher rate of ear infections than older children and adults. If you look at the position of the eustachian tube, young children have short and straight eustachian tubes versus in the adult patient it is angled more upward to allow for better drainage. So when children lay down and things like that, fluid from their sinuses flows into that eustachian tube, and then because of it not being angled as higher and being shorter and straighter, that fluid kind of gets stuck and leads to those middle ear infections. So a little A and P review, the biggest functions of the ear. Hearing is what we think of as well, but that inner ear also has a function of balance. And then we look at the external ear, middle ear, and internal ear. The external ear is the part we can see, that's the ear canal, and then the middle ear is that part behind the eustachian tube. So typically when people say ear infections, that's what you're thinking of, is a middle ear infection. However, you can also get ear infections of the external ear as well, and we'll talk about that in a second. So as far as how do we assess ears and how do we put drops in ears, otic drops. So when we're talking about both, we use the same protocol. So in order to straighten the ear canal, you have to tug on the pinna a little bit. When you're talking about children that are 3 and younger, you pull down and back. When you're talking about over 3, it's up and back. So down for the smaller kids, up for the bigger kids. And this straightens out that ear canal. So one, so you can visualize it better if you're assessing, but two, if you're using eardrops, it helps it drop down into the canal a little bit better. So on page 539 in your book, it does give that detailed view of the ear like you see in the picture, but this is really more just for a review of your A and P purposes. So like I mentioned, you can get what's called an otitis externa, which is an infection in that ear canal. A lot of times this infection is what people call swimmer's ear. It's where you get an infection of that external ear. It's typically quite painful when you pull on the pinna of the ear. As opposed to middle ear infections, oftentimes you'll see children where they pull on the ear to actually make it feel better, versus this is quite painful when you pull on it. So the treatment for this is going to be eardrops. Because of the location of it, oral antibiotics typically don't help. They don't perfuse the area well enough to get those drops to where they need to get those oral antibiotics systemically where they need to be. So drops are often used. If the ear canal is too narrow because of swelling that the drops will not go in, we can put a wick in, and that's what you see in the picture. That little white piece in the canal, that's called a wick. It's a piece of cotton that we can stuff basically in the opening, and it sucks up those drops and pulls them in further into the canal. When the canal is so swollen shut, you can't get those drops in. The other type of infection, and this is what most people think of when they say an ear infection, is an otitis media, which is a middle ear infection. So this is where you have infected fluid behind that tympanic membrane. So when you look in the ear, you'll see something like the top picture where it's on the left, where it's very red and inflamed. You may even see purulent fluid behind that eardrum. So signs and symptoms, oftentimes in babies and very young children that can't really communicate that their ear hurts, you'll see them either pulling on their earlobes, or they may pat that side of their head where their head is, where the affected ear is. You may see them shake their head back and forth. Various different signs showing them that they have irritation in that ear. We get very concerned with middle repetitive ear infections in children under 2 because under 2 is the greatest expanse of speech development in your life. Most of your development happens during that time. So the problem with ear infections is every time you get an ear infection, you get a slight bit of scar tissue. One or two, not a problem. But when they're repetitive, it builds up enough scar tissue that it thickens and hardens that tympanic membrane to where it doesn't function appropriately. And as they start to have hearing impairment because of that scarring on the tympanic membrane, that hearing impairment can lead to speech impairment. So when we're talking about hearing loss and impaired hearing, when we have a newborn, so not acquired from ear infections, but a newborn that has a hearing impairment, they may not react to like the Maro, for instance. If you clap near their ear and make sounds, they don't turn towards the sound or have that startle or Moro reflex. When we're talking about children that are developing those speech skills, like 2 or so, 1 to 2 years old, then if they are starting to slack on those speech skills or not talking, that's usually the first thing they look at is hearing. When my son was evaluated for speech therapy when he was 3, that is the first thing they asked me: has he ever had a hearing evaluation and was it abnormal? So that's usually the first thing they look at when there's any potential for speech impairment. Um, so the manifestations are on page 539. Again, with younger children, especially, you see the head shaking, you see the pulling on the ear, crying. Maybe they often don't feed as well because that's especially if they're bottle fed still or they're breastfed. That sucking action puts pressure on those ears and can make it worse, make that pain worse. So they don't want to eat very well. Um, so when we're talking about a patient that has chronic otitis media, this is when they'll look at those ear tubes, which is the picture you see on the bottom. It's usually a very small tube. It is usually a bright color so you can see it well, like this one in the picture is green, but sometimes they're blue or orange ones that I've seen. And it's there to basically create a canal in the tympanic membrane so any fluid that gets trapped in there can be drained out, which is a really good thing because that's a big reason that we see repetitive ear infections in those younger children is because of that fluid getting trapped due to those short and straight eustachian tubes. So this allows a way for that fluid to drain. So seeing drainage out of a child with ear tubes is not necessarily concerning because that's an expected thing that you will see. And these tubes fall out on their own after a period of time. Typically, sometimes they don't fall out on their own and they start to attach to the tympanic membrane, and the surgeon has to go in and surgically remove it. But ideally, most of the time, they will fall out on their own. So, speaking of hearing impairment, so like I mentioned, hearing impairment can affect their speech and language skills. When their speech and language skills are impaired, that can affect their behavior and their emotional development and all those things that start to develop in school when they have those impairments. So, hearing impairment can be a variety of causes. One cause, again, is those chronic ear infections. Another cause can be varicella and rubella, especially if mom was exposed during pregnancy. That can lead to hearing loss, varicella and rubella both. It could be noise. So we think of loud noises as causing hearing loss, but especially in newborns and preterm babies, repetitive, frequent noise can cause hearing impairment. Take for instance in the NICU, it used to be when I worked at MCV, the NICU was just one big giant room with babies stacked next to each other, basically. So babies in there were hearing the dings of the monitors, of the other patients' IV pumps. It was a constant din of noise in there. It was just constant noise, and this could impair their hearing, especially in a premature baby. So you'll see most NICUs nowadays have individualized rooms, one so the parents can stay, but also it allows decreased stimulation because preterm babies especially don't need a lot of stimulation. It can also be acquired later on through medications that we give. Remember, going back to farm, your ototoxic antibiotics like your gentamicin and all, you have to have concern over hearing impairment from those and the use of those. So how do we address hearing impairment? There's various different things, and it's going to depend on the severity of the impairment, what we do for that. So the picture you see is called a cochlear implant. Those are going to be obviously more severe cases, but this implant allows their brain to connect those vibrations to the tympanic membrane, essentially almost like bypassing that tympanic membrane and allowing them to be able to have that hearing sensation. Other methods we can use, we have picture cards that we use, so patients that can't verbalize or can't hear, we have basically a big poster that has pictures of what they need, and they can point to what they need. Like they can point to the toilet if they need to go to the bathroom, or they can point to the cup if they want something to drink, or there's a yes and no they can point to answer yes or no questions. Those are effective, especially with younger children and the picture ones. They can also patients learn sign language. We also want to make sure if they're hearing impaired and not totally deaf, that we are using appropriate measures to communicate with patients that are hearing impaired. And this goes for pediatric patients as well as adult patients. You want to make sure that you're at eye level with the child. And this again goes for adults as well. You want to be closer to the child. You don't want to be at a distance. You want to make sure there's good lighting when you're talking. You want to use short phrases. You don't want to do like I am right now, where I'm going on and on for an hour about things. You want to give them just little pieces of information so they can process the lip reading that you're doing. And that's where all this goes to, is that lip reading, so that they can actually see. You don't need to overly enunciate and exaggerate your facial movements, but just making sure that they can clearly see the movements of your mouth. Those are some parameters to help with the lip reading. So the other sensory organ we'll talk about is the eyes. So the eyes start to develop in a very early embryo. Oftentimes the eyelids are fused closed early on in pregnancy and open later, but they are present. Like we talked about with newborns, they do not have tears for lubrication for the first couple of months. So if we're seeing tears in a newborn, that's a sign of potentially a clogged tear duct, for instance. So a detailed picture of the eye is on page 542. Again, this is just for anatomical purposes for you to look at and see the parts and connect it to what we're talking about. So as far as eyesight, in an infant, there's not really any diagnostic testing that's specific. A lot of it is evaluated by if they follow lights and things like that. If they don't appear to turn their head towards lights or things like that, that may be a sign of some kind of vision impairment. Typically, actual testing of vision starts about the age of 3. You'll see a lot of testing that we do starts at the age of 3, like blood pressures, hearing and vision, things like that. Maybe even 4, depending on the provider. So their vision is very, very poor when they are born. They can basically just see fuzzy shapes, and black and white. They can see the best, and bright primary colors. It's not until they're about 6 or 7 years of age when you expect them to have that 20/20 vision. So it does take several years before their visual acuity really sharpens to the point that we would expect them to have as an adult. So the different types of visual deficits, you have myopia and ones like that. Make sure you know the difference, your farsightedness, your nearsightedness, and all that. A couple things that oftentimes people either haven't heard of or they may have heard of and didn't know the names for it. One is called strabismus, and this is the picture that you see on the screen. Strabismus is, if it's bilateral, they may be cross-eyed, or like the top picture, it may just be one eye. It's a weakening of the motor muscles of the eye. So one of them is weaker. One set of them is weaker, so the eye will kind of deviate away from the other eye and not follow visual like you would expect it to. So this can, because that eye is wandering, can lead to amblyopia, or you can have amblyopia happen all by itself. And what amblyopia is, where you have a reduced visual acuity in one eye. So if you have an eye, for instance, with strabismus, where the muscles are weaker and it kind of migrates over, then that acuity can also weaken in that eye because it's not focusing on things like it needs to. Oftentimes, this is what you hear people think of strabismus as lazy eye, but this is actually lazy eye because one of them is not as sharp in the visual acuity. So the thing with amblyopia and strabismus is the treatment is the same. As you see the picture of the boy on the screen, they patch the good eye. So if you patch the good eye, you're forcing the eye with the difficulties to work harder. And the idea is, if it has to work, just like when you work a muscle, if you work a weakened muscle, it'll build that muscle up. So it's essentially like physical therapy for the eye, forcing that eye to focus and work. Typically works pretty well. If it doesn't, then surgery procedures might have to be done. But this does kind of work pretty well. All right. Our other eye infectious disease is called conjunctivitis. So there's various different forms of conjunctivitis. It basically just means inflammation of that eye covering. So you can have allergic conjunctivitis, where you get the eye redness and itching and all just from allergic reactions. But most of the time when people think of conjunctivitis, they think of pink eye, the infectious eye infection. So this can be viral. In fact, most of the time it's viral, or it can be bacterial. But this is one of those things, because you really can't differentiate between a viral conjunctivitis and a bacterial conjunctivitis. They treat everybody. So this is treated typically with eye drops. It's highly contagious. A lot of times, children as well as adults, if they get conjunctivitis in one eye, it's probably going to spread to the other eye, even with meticulous hand washing and avoiding their face and using their drops. Very, very easy to spread. So typical symptoms, oftentimes they will have discharge like you see in the picture, thick, purulent discharge. A lot of times children and adults as well, when they wake up in the morning, their eye will essentially be glued shut as it has dried overnight. Oftentimes they have itching, pain. Sometimes people describe it as a sensation of feeling like there's sand in their eyes. So those symptoms vary a little bit depending on the patient, as well as the offending microbe that's causing it. So again, we always treat it with eye drops. Again, this is not done with oral antibiotics, systemic antibiotics. Eye drops are very effective in this manner. A little tip for how to give eye drops to babies, or even any child, even adults that don't want to open their eyes, because with infants and young children, you'll find if you're trying to force their eye lid open to access their eye to give them drops, the harder they're going to squeeze and the more potential you have to cause trauma to that eye. So the easiest way to do this with adults as well as children is lay them flat on their back and drip the eye drop into where that lacrimal duct is in the middle of the eye, and then wait and just have them lay on their back until they open their eyes, and it will just run right in. Greatly decreases the risk of any trauma that may be done to that eye if you're trying to force that open. So question, we talked about this a little bit when we talked about pediatric care, but let's see, once you start on some kind of pharmacological treatment for bacterial conjunctivitis, when can you return to school? So the answer is 24 hours. 24 hours is the answer to, if you 24 hours on antibiotics, like in this case with conjunctivitis, 24 hours on antibiotics. If it is a febrile illness like the flu, for instance, you have to be 24 hours fever free with no antipyretics in order to be considered not contagious anymore. So 24 hours on antibiotics and or 24 hours fever free with no medications to resolve that fever. And in some cases they will do longer. Like for instance with the coronavirus right now, they're requiring people to be out for 72 hours past their last fever. A lot of places are. So depending on the situation, that may be longer, but minimum is going to be 24 hours. So the last thing we'll talk about the eye is an eye tumor. It's called a retinoblastoma. You typically see this in infants. Sometimes children are born with it, or you may see it in the early toddler age, like 1 to 2 years old. This is not typically something you see in adults or older children. I'm sure you've probably seen posts on Facebook where it will say taking a picture of my child saved their life. The easiest way to diagnose a retinoblastoma, and often the way it is caught, is that picture up at the top. They lack a red reflex. So I know our cameras have gotten really good nowadays where you don't see the red reflex as much, but it used to be, back in the day when I was a kid, everybody had demon eyes when they had their picture taken because of that red reflex. The flash of the camera would cause the light to bounce off the back of the eyeball, which creates that red reflex like you see in that child, the top picture, the left eye. If there is a tumor blocking that retina or blocking the back of the eye, instead of it reflecting off the back of the eye that's red and causing a red reflex, it causes a white reflex, which is the right eye that you're seeing on that top picture. So when you see those two different colorations of red reflex versus white reflex, that's pretty indicative that there is a tumor. The good news is most children do well with this. They do have to remove that eye in order to treat the tumor. You can't just take the tumor out itself, but typically children do really well with this. All right, so let's move on to the neurological system. So hopefully by now you know how to do a neurological assessment. Really, it's no different in children than it is in adults. Sometimes the way you carry out the assessment may be different. Like for instance, if they can't answer questions to determine if they're alert and oriented, you have to alter that. And we'll get to that in a second with the Glasgow Coma Scale. On page 547 in your book, it does show locations of the brain based on functional areas. So hopefully you know by now you have an idea of which parts of the brain kind of do what functions as an overview. And the reason this is important to understand that is especially with things like brain tumors or anything that alters the pressure on the brain. Symptoms that you see may help you determine the location of the problem. Like, for instance, if they're having gait problems like ataxia where they're stumbling, that might indicate to you there's a cerebellar problem, or if they're having problem with memory, that's a cerebral cortex problem. So those kind of things are why it's important to know what those different functions of the brain are doing. So on page 549, it talks about reflexes, newborn reflexes. The reason we check those newborn reflexes is because if they are abnormal, that can give us a very early indicator of nervous system dysfunction potentially. So that's sometimes the first thing we can, if it's a congenital neurological problem, that can be sometimes our first sign to indicate there's a problem. When we're talking about level of consciousness, it starts all the way at the top, alert and oriented, just like in adults, all the way down to permanent vegetative state. And there are various levels in between: lethargic, obtunded, confused, things like that. And the way we can most accurately determine the level of consciousness and put a an objective number on that is to use the Glasgow Coma Scale, or GCS score. I'm not sure if you've talked about this in MedSurg yet, but this is we do it the same way. It is evaluated the same thing. We look at three things, and you're going to want to know what those three things are that we look at. We look at eye opening, motor response, and verbal response, just like in adults. The top number is 15. The lowest number you can get is 3. And the reason this is so important is level of consciousness, especially this that gives us a objective way to determine level of consciousness, is the best indicator for neurological functioning. You need to know that the best indicator is level of consciousness. So I don't necessarily want you to memorize all of it so that you would have to give me a score, but you should definitely know what's involved. The three components of the Glasgow Coma Scale. When we're talking about how is the pediatric GCS score different than an adult. The only way it differs is verbal response, and more specifically, how we have to obtain or assess that verbal response in a younger child that is not at the level of, say, an adult orientation. Like you see at the bottom, and I know it's kind of hard to see, but it says patients that are greater than 5 years. You can ask them questions and see if they're oriented. But under that, you have to look at developmentally wise, are they appropriate? Like, for instance, an infant, if they're cooing and babbling, that's a sign that they are appropriately interacting verbally, as opposed to actually answering questions, because they can't do that at their age. So that is the best way for us to assess neurological functioning. So one of the things that most people have at least heard of is called Reye syndrome. This is related to giving aspirin to children. It's specifically when they have a viral illness. So this is why it is recommended that no child should ever get aspirin with an acute infection. There are very specific reasons. We do give aspirin to select children if they have rheumatoid arthritis, for instance, if they have Kawasaki's disease, which we'll talk about in cardiac. There are very specific things we give aspirin for to treat, but as an overall, children should not be given aspirin. There is potentially a genetic component that makes people more susceptible to interacting with that aspirin, but it's just best to avoid in everybody. And specifically, what happens is when patients have either varicella or influenza and are given aspirin, it's the reaction of the two. Oftentimes, it is a liver reaction, and the problems are caused by that liver impairment. However, it is classified as neurological disorder because that ammonia that builds up because the liver can't process the proteins properly and get rid of the byproducts builds up on the brain. So the symptom, even though it is a hepatic dysfunction or liver dysfunction, the ammonia that builds up on the brain, their symptoms are going to be neurological. So they are going to progress pretty rapidly. They'll have altered level of consciousness. They may have behavioral changes. They may even have seizures and coma, depending on the severity. It shows you in the picture the clinical staging. I do not want you to memorize the clinical staging for Reye syndrome, but that shows you, just gives you an idea of, one, what the symptoms are, and also how it can progress. Typically, children recover from this that get it. However, oftentimes they have some kind of permanent neurological or cognitive impairment. So it is important to prevent this. And it's very rare that you see it nowadays for two reasons. One, people are getting immunized against varicella and influenza. So if they're getting immunized, they're less likely to get the infections. And two, our public education of avoidance of salicylates and aspirin, specifically aspirin, is has gotten out enough that people know, as a general population, typically not to give aspirin to children. So public education on immunizations as well as avoidance of aspirin has helped us greatly to alleviate this problem or prevent this problem. So something you should be familiar with is meningitis. Meningitis is an infection of the meninges, the covering over the brain. They're going to be either viral or bacterial. We're going to focus on bacterial because bacterial is the one that people get hospitalized for. It's the one people are more likely to die of. It's the one that people get put on droplet precautions for. So this is, again, an irritation or infection of the meninges. So symptoms of this, you see the symptoms on the chart at the bottom: vomiting because of the increased intracranial pressure. Oftentimes they have fever, pretty high fever. They may have a skin rash. The picture that's at the top right-hand side, you'll get that meningococcal papular rash, especially in children. You see it more often. The the hallmark symptom of meningitis that if you ever see this symptom, you should automatically connect it with meningitis is called nuchal rigidity. Nuchal, rigidity. This is neck rigidity. This is the hallmark symptom of meningitis. If you see that, meningitis should be what comes to your mind as the cause of it. So your priority intervention in these patients is to put them on droplet precaution. So meningitis is droplet spread. It starts often as a respiratory infection. Strep can cause it. Agents that cause sinus infections and colds and things like that can spread and become meningitis. So they are spread by respiratory route. They often start as respiratory infections. So your priority, if you ever have an answer of put them on precautions, and this goes with any infectious disease, period. And Klex loves these questions with what's your priority in this infectious disease patient? Precautions. Obviously, you need to know because often it's not going to just say isolation. It's going to say it's going to have specific types of isolation. So knowing what type of isolation to put them on is an important nursing skill to protect not only your safety, but the safety of other patients in that area as well. So we diagnose meningitis by a lumbar puncture where they stick a needle into the spine and withdraw some of the cerebrospinal fluid. They can test for bacteria and white blood cells and do a culture and determine specifically what is the contagion that's causing the illness. And then if it is bacterial, they treat with IV antibiotics, and people typically do well. And on top of antibiotics, you want to make sure that you're doing at least every 2 hour neuro checks and vital signs. And you want to decrease stimulation. So a big theme of neuro when we're talking about neurological disorders is decreased stimulation and making sure they don't lay flat because that increases that pressure on the head and can make it worse. So as far as brain tumors, I do not want you to memorize the different types of brain tumors. There are multiple different types of brain tumors. It is the number one solid cancer in children. So the most common cause of cancer in children is leukemia. The second most common cause of cancer is brain tumors, and it is the most common for solid tumors. So there's various different ones. I gave an example with the picture to show you where they can be. That some of them are very slow growing, more benign. Some of them are rapidly growing. The location creates an impact of treatment as well as how rapidly it grows. So again, depending on where the brain tumor is located can impact what their symptoms are. So if it's located, say, in the temple area, then it might be memory problems or things like that. So some of the symptoms that you'll see as general symptoms is um, their intracranial pressure. The pressure inside their head increases because of the pressure of those tumors. You'll get things like headaches and vomiting, seizures potentially. You can get nystagmus, which is the picture that you see to your right, where their eyes will jump up and down or side to side. If you are following along with the PowerPoint pulled up with the video, then if you go to the PowerPoint itself and you click on that picture of the eyes, you'll see what a video of what nystagmus looks like. So typically a lot of your symptoms are related to that increased intracranial pressure. Symptoms are listed on page 551, but you can have other symptoms related to the specific location of the tumor. So treatment of brain tumors is going to depend again on the severity of the brain tumor as well as how rapidly it grows and where it's located. If it's located, for instance, near the brainstem, that makes it a little bit more difficult to actually remove that tumor. Making sure to decrease stimulation, having their head elevated at least 30 degrees, monitoring eyes and nose, frequent neuro checks. That's a common theme in all of our neurological disorders. All right, so hopefully by now you know a lot about Seizure disorders. This is covered a lot. There's a lot of people that have seizure disorders. You can have partial seizures, which is where, to go to this picture that's on the next slide. Your partial seizures are, patient is often awake and conscious, and they may have like a tick in their face. They may have an arm twitch. They may have an auditory sound. Like for instance, when people talk about an aura, where they hear maybe a sound before they go into a tonic-clonic seizure, that could be the beginning of that partial seizure. So a partial seizure is where it's just a section of the brain that's affected. This can then turn into, as it spreads and gets too excited, to a generalized seizure. So there's two main types of generalized seizures. There's your tonic-clonic seizure. You'll also hear it called a grand mal seizure, but that is kind of old terminology. Tonic-clonic is what you'll see currently the terminology used. And this is what most people think of, that writhing, rigid, jerking movements, rhythmic movements. They are not conscious. They are not aware of what's going on. And this can last anywhere from a few seconds to several minutes. It is, hopefully, you know your seizure interventions by now. Your number one priority for all patients that are having a seizure is their safety. The nursing actions are described on page 554. And it goes into all the safety things, like the stuff hopefully turning them on their side, protecting their head, not putting anything in their mouth, not restraining the patient. Things like that are very, very important. The other type of generalized seizure is called an absence seizure. And again, tonic-clonic and the absence, the words are highlighted because if you're following along with the PowerPoint, you can click on those and see a video of each one to see an example of what it looks like. The other category that you don't talk about in adults is called febrile seizures. These don't happen in adults. Typically, if a child has febrile seizures, they go away by the age of 5. They just start to resolve on their own. There does seem to be a genetic component related to febrile seizures. You see siblings that will both have them. If a child has had them before, they're more likely to get them again. Now, a common misconception in society is that febrile seizures are based on how high the temperature gets. And it's not based on how high the temperature gets, it's based on how rapidly it increases as well as decreases. It used to be with patients that had a high fever, we would wipe them down with alcohol or put them in a cool bath, things like that, to bring down that fever faster, but they have found that could actually be detrimental. If you bring it down too fast, you can stimulate a seizure that way as well. So we just use medications, take off extra clothing, things like that. So febrile seizures, there's no treatment for it. They're not put on anti-epileptic medications. If a seizure goes on for more than 5 minutes, they may give them lorazepam in the acute event. But other than that, there's no treatment for it. It goes away. It doesn't cause the permanent neurological impairment like a epileptic disorder can when they're having repetitive seizures. So how do we treat um, seizure disorders? There's lots of causes of seizures, like the video we watched of Joshua Barron. His seizures were caused by his head injury and the pressure in his head from that cerebral swelling. It could be meningitis can cause seizures if they have that acute infection. There are various things that can cause seizures. Sometimes it's idiopathic. You don't know what has caused it. And a lot of times that's where people get diagnosed with epilepsy. So the gold standard for diagnosis is an EEG, an electroencephalogram. You see a picture of that on the left-hand side of the screen. The top one is normal brain waves. The bottom one is when they're having a seizure. So you see it's very excited, bouncing all over the place. So a lot of activity going on there. So how do we treat it? Well, the gold standard of treatment is anti-epileptic or anticonvulsant medications. Phenytoin is a common one that we use. Depakote is another one that we use in pediatrics. So with these medications, they decrease that overexcitability of the brain. Do they have to be on these medications forever? No, not necessarily. Some patients, especially when they have seizure disorders that are diagnosed in childhood, they may grow out of them. So, how do we get them off these medications? So, as far as getting them off the medications, the criteria is they have to be 2 years seizure free in order to not have to take these medications. Completely seizure free, no seizure activity for 2 years. And then once it's decided they can come off of it, it is done in a tapered fashion. So, because if you just stop it, then that can actually stimulate a seizure. If they have a seizure disorder, you have to be careful about things like children that ride bikes. A lot of times they can't ride their bike. If you have a driving teenager or even an adult, every time they have a seizure, they have to wait 6 months from that seizure in order to be able to drive. And that's a state law in Virginia, as well as many states. So making sure they know those potential lifestyle effects too of having a seizure disorder. So other ways that we can treat it besides medications, there's something called a vagal nerve stimulator, and it's what you see in the picture. That device on the left hand side of your screen is implanted under the skin. The wire is wrapped around the vagus nerve. This wire then, when it's activated in the picture on the right, she's holding a magnet up to her chest, which activates that stimulator, which stimulates the vagus nerve, potentially, hopefully, stopping that seizure. They are making more devices now where you don't even need that external magnet device attached to it, which is good for patients when they're alone because they can't really do that if they're having a seizure and they're alone. Then it will automatically kick in, kind of like an automated AED, and it will recognize that they're having a seizure and automatically kick in. So that's a really nice thing to have, to help with those seizure disorders. So the last thing we're going to talk about, um, well, next to last thing, really. This is probably one of the most common permanent neurological problems we see in children, is called cerebral palsy. So cerebral palsy is not genetic. Even though somebody may be born with it, it may be congenital, it doesn't mean it's genetic. If it's congenital, it's probably where they had some kind of injury in utero. So the most common cause of cerebral palsy is an anoxic, or it is a brain injury, most commonly an anoxic brain injury, meaning a lack of oxygen to the brain for a certain period of time. So when we think of injuries, we think of like traumas, but it does not have to be um, any kind of trauma. Like you're thinking of. It can be a lack of oxygen that still causes it still causes that injury to that tissue. So there are four common causes. The third one is a mixed, or four different types, I should say. The third one, or the fourth one, is a mixed type. So you'll see characteristics of all. Make sure you know the differences in them, especially spastic, because spastic is the most common type of cerebral palsy. Spastic is where they have writhing movements and spasticity with stimulation. So at rest, patients just sitting in the chair, laying in the bed, their muscles are calm. If they get stimulated, like it could be just you talking to them, it could be you touching them, they'll start to have the shaking, spastic movements. The only way to really treat cerebral palsy, you can't treat the disease, but we can treat is the symptoms. And a common drug that we give patients with cerebral palsy is baclofen. Baclofen helps with those spastic movements. So other than that, if they have like ataxic, for instance, where they have difficulty with walking, they may have what's called scissor walking, which is what you see in the picture on the left-hand side of the screen, where the knees kind of cross and the toes point. If you click on the picture, you will see it will open up to a video to give you a better example of what scissor walking looks like. So it's very hard to diagnose cerebral palsy in an infant, because they may not show symptoms. They may not show symptoms of it until they start to not be meeting those milestones, especially your gross motor development. So how do we treat it? Again, we can't treat cerebral palsy in and of itself. Our treatment is surrounded around preventing complications. Patients, especially spastic patients with spastic cerebral palsy, have a higher risk of things like contractures. So preventing those complications, encouraging as much movement as possible. Making sure those muscles are being worked and stretched out, because sometimes they have some muscles that have hypertone or too much tone. Sometimes they have muscles that don't have enough tone. Um, so making sure to work those muscles and using physical therapy to decrease complications, including impaired skin integrity that can happen in various different things. So preventing complications and maintaining their functionality as best as we can. The last thing we'll talk about related to neuro is head injuries. So this is a traumatic type of head injury. Most people, when they think of head injuries, they do think of concussions. Concussions can be difficult to diagnose because there's really no diagnostic test. It's all symptom based. There is a scoring scale that we use where we have the patient fill out the severity of their symptoms, so that we can determine how bad the concussion is, but it's not like it will show up on a CT scan unless it's pretty severe. So with concussions, there is a big thing about concussions in the news. I mean, in the news, in sports, especially because concussions can be a big deal in sports. And the reason it has become a big deal is because children who have not, and adults as well, anybody who has not fully recovered from one concussion, if they suffer a second concussion, they can have a rapid decline in death. So because of this, you want to make sure they are fully reformed from that first concussion before you put them at risk of a second. So coaches, especially in sports, have to be very, very on top of this. They typically, even if they suspect a head injury, will not allow a child to come back and play until they have a doctor's note clearing them. In order to be cleared, doctors require 7 days completely symptom free. Now, the most common symptom associated with head injuries is headache. Pretty much most patients get a headache, even if they have no other symptoms. Now, that can be hard to determine because, especially if you have a motivated teenager that really wants to play their sport, they may hide the fact that they have a headache because teenagers think they're invincible and nothing bad is going to happen to them. So if they're motivated to play and they don't want anybody to know that their head still hurts, they'll hide it, and then have that increased risk of pretty serious complications.